Okay, we're going to try to do a quick video on congenital heart disease. So this is actually a little bit before I started talking about congenital heart disease in class. This is more of the concept stuff, but some of this stuff is important to know. So things like if we have an infant that is a poor feeder, poor weight gain, if they are failure to thrive, sometimes these can be signs that we have an undiagnosed congenital heart defect. If they have a dusky color can actually be a sign of like that polycythemia sometimes, so that can be a sign as well. If you see a child, a toddler or children squatting and seem to be fatigued, and when they're fatigued they squat down, that can actually be a sign that they are trying to manage it themselves to increase that systemic congestion and get it to return to the heart. If you have developmental milestones, if you have failed to meet the developmental milestones, those can be signs as well. Okay, so some of the common lab tests that you see. So anytime we're thinking about the heart, if we had somebody that came in with potentially a heart attack, the cardiac enzymes would be what we would look at, like our troponin levels, right, would be what we would look at. Serum lipids, that's important because we're thinking about atherosclerosis. We're thinking about that fatty lipid deposits throughout all of our blood vessels. Our complete blood count, so looking for things like polycythemia. So what does polycythemia mean? Remember, polycythemia means having too many RBCs, right? A whole bunch of RBCs. So it's an adaptation that the body does when you have heart failure to try to increase perfusion to everything in the body. Okay, so it can be a sign of heart failure as well. We look at blood coagulability as well, because the risk of thromboembolism, bone marrow biopsy, leukemia, that kind of thing could definitely be important to understand the blood and perfusion. And then BNP, brain natriuretic protein, brain natriuretic protein. So this is something that we specifically look at to identify worsening heart failure, okay? So it is specifically what we look at to identify worsening heart failure. Brain natriuretic protein it's released from the brain whenever we have a concern with our perfusion, okay? And so it is a specific marker that we look at for worsening heart failure. And then electrocardiogram, we know that, I think most people refer to it just as kind of our EKGs, but our ECGs. Cardiac stress test, I know you guys have learned about most of this stuff, so I'm not too worried about teaching that to you. Okay, the brain natriuretic protein and the cardiac enzymes, you probably have learned about troponins, but really that BNP is kind of what I wanted to pull out from this. So prenatal blood flow, it's important to kind of review your prenatal blood flow to understand some of our congenital heart defects. So we have 3 adaptations within the fetal heart. This is the fetus heart. This is not the maternal heart. This is the fetus heart. So the ductus venosus is where we have our blood supply coming through from our umbilical artery, right? So this is where we have our blood supply goes through the liver. It's the ductus venosus, and it comes in, dumps the blood into our atria. And one of the very first adaptations is once we get to the atria. So we have something called a foramen ovale. It's like a little flap. And what happens is when they are in utero, they have, their lungs are not working right. So they actually have significant pulmonary hypertension. So they have very, very, very little, if any, blood flow to the lungs. And what happens is that increases the pressure in the atria, and actually it keeps that foramen ovale open, okay? So when they're born and they take that first breath, and now we're perfusing the lungs, it decreases the pressure, and that actually allows that flap to close. Okay, so the foramen ovale is one of the first adaptations, first things that closes when they're born. Okay, once they're able to take that good breath. The other adaptation is adductus arteriosus. It's right here. Let me turn on my little thing. Right here, adductus arteriosus. It connects our pulmonary artery to our aorta. See that? Okay. So looking at our postnatal blood flow, you see our foraminal valley has closed. Eventually, our ductus arteriosus is going to turn into this ligamentum arteriosus. Okay. And so it is supposed to close, and then our ductus venosus turns into this ligamentum teres. So it's not, doesn't connect to anything, right? So kind of reviewing our blood flow. Sorry, I told you it's 2 hours of sleep. Anyways, kind of reviewing our blood flow. We have our superior and inferior vena cava that dump our blood into our right atrium, right? It goes down through our tricuspid valve here, right? Down into our right ventricle, and then our right ventricle pushes that blood to our pulmonary artery where it goes to our lungs to get that wonderful oxygen, right? Comes back from the lungs through our pulmonary vein. Our pulmonary vein is going to dump that blood right into our left atria, right? Right into our left atria. And it goes through our mitral valve, also known as our bicuspid, right? Our bicuspid valve versus our tricuspid that's on the right. And then down to the left ventricle, and then left ventricle pushes it up to the aorta, right? And so you can see the aorta, you have the ascending part right here, you have the descending part of the aorta right there. And so it's important to understand your circulation, your cardiac anatomy to really understand some of these congenital heart defects. One really important principle to also understand congenital heart defects is kind of basic hemodynamics. So here's the thing. So blood flow is going to always flow, and just you can kind of think about this for anything. It's going to flow from a higher pressure to a lower pressure. So think about like if I had a tube and I go and I squeeze my tube, what's going to happen to my fluid? Well, is it going to go to something else that's really squeezed tight? No, it's going to go to something that's loose, something that is dilated, if you will, vasodilated. So it's going to go from a higher pressure to a lower pressure. Well, here's the thing. Pressure on the left side is higher than pressure on the right side. And it makes sense. What is the pressure on the right side pumping the blood to? It's pumping it to the lungs. Whereas the pressure on the left side is pumping the blood to the body, right? So it's got a lot more blood to pump it to. It's got a lot more area to pump it to. So the pressure on that side is going to be a lot more significantly higher. So this part is really important to understand because we are going to define our congenital heart defects based upon this principle. So resistance in our pulmonary system is less than our systemic system. So what we look at is, does the congenital heart defect cause increased blood flow to the pulmonary bed? Or does the congenital heart defect cause decreased blood flow to the pulmonary bed? Meaning more unoxygenated blood to the body. Okay, let's look at this. A little review on our tricuspid and bicuspid valve, not necessarily significant for us in this class at this moment. Okay, so I'm not playing the videos in this. This does go over like your congenital heart defect screening. It's not the best video in the world, but there's probably better ones out there. You remember you want to do your preductal, which is on your right hand or wrist, versus your postductal, which is on your left or right foot. It could actually be either one. I typically do left, so it can be my opposites. And we want our SpO2 to be above 95% and less than a 3% difference between our preductal and our postductal. So if I'm like 95 and 97, I'm good to go. If I'm 95 and 98, I'm not so happy. If we have an abnormal one, we'd want to do an EKG and a chest x-ray, and they're going to typically need an echo as well. So one of the things we look at is our classification of our defects, our acyanotic defects versus our cyanotic defects. Okay, so we look at whether a defect is acyanotic versus cyanotic, and this really has to do with that pulmonary blood flow. So our acyanotic defects that increase the blood flow to our pulmonary bed are our ASD, our VSD, our PDA, so atrial septal defect, ventricular septal defect, patent ductus arteriosus, and then also this atrioventricular canal, but we're not learning that one. That's not a big one. It's not one you need to know. Atrial septal defect, ventricular septal defect, PDA, coarctation of the aorta, and tetralogy of Fallot are the ones we will concentrate on. Okay. So those all increase blood flow to the pulmonary bed. You have this defect in that atria or in that ventricle. And what happens, because there's less resistance on the right side, more blood flow is going to flow to the pulmonary bed. Same thing with your PDA. It's going to go from your pulmonary or from your, if it's connecting your aorta and your pulmonary artery, it's going to flow right over to that pulmonary artery. Okay. The other acyanotic defects that you have is obstruction defects. So this is where we talk about our coarctation of the aorta and our aortic stenosis or pulmonic stenosis. Okay, they're acyanotic defects because you typically don't see cyanosis with them. Okay, you'd have to have a significant defect to see cyanosis. The next one is your cyanotic defects. So the one we will concentrate on is tetralogy of Fallot. That's the only one we're going to concentrate on. I'll talk a little bit about transposition of the great vessels and hypoplastic left heart syndrome, just because they're kind of terrible and kind of interesting. But they have mixed blood flow with them. So your acyanotic defects, meaning no cyanosis, ASD, VSD, PDA, coarctation of the aorta, are the ones we will concentrate on. You have a left to right shunt, meaning it goes from the left side to the path of least resistance, the right side. Increased blood flow to the pulmonary bed. Acyanotic defects acyanotic defects also include the obstructive defects. Your cyanotic defects, meaning they have bluish grayish color of their skin, nails, lips, or around their eyes. Tetralogy of the Fallot is the big one we're going to concentrate on. You have a right to left shunt, a decreased blood flow to the pulmonary bed. Okay, mixed blood flow as well. Meaning mixed blood flow, by the way, means oxygen and unoxygenated blood in the system, right? So our increased pulmonary blood defects, ASD, VSD, PDA, our obstructive defects, coarctation of the aorta is the one we'll concentrate on. Our decreased pulmonary blood flow defects, tetralogy of Fallot, and then our mixed defects, we're not going to concentrate on those, but those are listed. And repeat one more time. I'm going to continue on. So our ASD, I do recommend watching this video at home if you were not in class on Tuesday. Our ASD, you can see we have this this path in between our two atrias. And so we know that the blood is going to go from the left to the right, and you're going to have more of that oxygenated blood going back to the lungs, which is not needed, right? You have a loud, harsh murmur. Please concentrate on the murmurs that you see with each of these. A loud, harsh murmur. You can see mild heart failure. They are often asymptomatic. Sometimes, I've actually seen statistics that say about 60% of us are walking around with an ASD. It doesn't cause us any problems. It's a really small defect, generally totally fine. However, it can increase somebody's risk for having more complications like heart failure and atrial dysrhythmias, but also things like myocardial infarction and stroke. When I told you guys in class about my husband's stroke was caused by an atrial septal defect. So when you have a client who's, in their 30s and having things like a stroke or myocardial infarction, this is one of the things that they look for. Okay. Ventricular septal defect. So our ventricular septal defect, again, your defect is in the ventricle. You have the left to right shunt, meaning more of the oxygenated blood is going back to the lungs, which we don't want, that's a waste. You have a loud, harsh, hollow systolic murmur, a loud, harsh, hollow systolic murmur, ventricle harsh, or the hollow systolic. You have typically more heart failure and failure to thrive with this one. It's a lot of times a lot more significant. Small defects can still close spontaneously. Large defects can cause Eisminger's syndrome, which is basically worsening heart failure caused by that VSD and associated with other things for Eisminger's syndrome. They require surgical closures. This is one of the defects that's commonly associated with Down syndrome. So this is one of the defects. My nephew had more than one, but this is one of the defects he had. Patent ductus arteriosus. So remember that ductus arteriosus connects that pulmonary artery to our aorta. Typically, it's supposed to close. It should close. A lot of times it closes within that first 24 hours, but it can take up to 72 hours without us being concerned. If we hear a murmur, this is one of the things we first kind of think about. It's a machine-like murmur. Machine-like murmur for your PDA. Machine-like murmur. Okay. Things that you can see is you can see wide pulse pressure, so a large difference between their systolic and their diastolic. Bounding pulses. Sometimes, though, they're completely asymptomatic. It can require sometimes medical intervention. Also, we can do indomethacin, which is a prostaglandin inhibitor. So prostaglandins keep it open, and a prostaglandin inhibitor closes it. So indomethacin is the drug of choice that we use. Obstructive defects. Coarctation of the aorta is the one we're going to concentrate on the most. So watch this video, but what do you see with coarctation of the aorta? So first of all, you can see where you have the coarctation typically does not affect the ascending part of the aorta. It affects the descending part of the aorta. So one of the things that you can see with your patients is differences in their upper extremities versus their lower extremities. So increased blood pressure and increased O2 saturation in their upper extremities and a decrease or absent pulses in their lower extremities, okay? So increased blood pressure and O2 saturation in upper extremities, decreased or absent pulses in their lower extremities. The signs that they can have with it is a systolic murmur with an injection click. So a systolic murmur with an injection click is what you can see with it, okay? And then it depends on how bad the defect is. One of the things that we might do if we suspected coarctation of the aorta is doing a blood pressure on all four extremities. So that is actually a very common thing that you might have a provider ask if you have a baby that's failed that critical congenital heart defect screening is, hey, can you do blood pressures on all four extremities so I can compare them? So two other ones of our obstructive defects. These are not necessarily ones that you need to like make flashcards to memorize, but please do it for the other ones. Your pulmonary stenosis and your aortic stenosis. So we know stenosis means like a narrowing, right? So your pulmonary stenosis, we can have right ventricular enlargement. So we have that right ventricle is working really, really hard to try to pump that blood to our lungs. So these can lead to right-sided heart failure. Aortic stenosis can lead to left-sided heart failure, right? So that's where the exercise intolerance comes from, is that we're talking about having heart failure along with it. They have a systolic ejection murmur with a palpable shrill, so you can like feel it almost vibrating. Cyanosis with severe narrowing, and it really depends on just how severe it is, and it may require a heart cath or surgery. We're going to talk about heart cath in a second. Aortic stenosis, so again, left ventricular enlargement, have to work harder than to push that blood out to the body, and you start having the symptoms of heart failure. Remember, heart failure is another one, so if you haven't watched it yet, please do. But you can have a murmur, chest pain, exercise intolerance, weak, thready pulses, hypotension, dizziness, syncope, and may require surgical intervention. So cardiac cath. This is just a quick talk about the cardiac cath. We want to make sure we have pressure dressing to the site. Bleeding is a huge risk with a cardiac cath. A hematoma at that site is also a huge risk with a cardiac cath. So these are reasons why we keep the leg immobilized. So it can be done through the femoral artery. Sometimes it's done on one side, sometimes it's done on both sides. And then recently, we've actually been able to do it through the radial artery as well. It is a little bit less risky, although it might be a little, I'm not a cardiologist, but it might be harder to visualize, I'd imagine. We want to monitor the pedal and post-tibial pulses. So we always say we have a Doppler at the bedside. We actually would mark where the pulse is and have that Doppler at the bedside. If we don't feel the pulse, we want to check it with a Doppler to make sure we're still getting some perfusion, okay? It kind of changes our level of emergency if we know we're getting some perfusion. We want to monitor the sites as ordered, monitor their pulses as ordered. So I would say Q15 for the first 1 hour to 2 hours, Q30 for an hour, etc. And monitor the vital signs. So our last one that we're really going to concentrate on is our tetralogy of Fallot. Okay. So tetralogy of Fallot, please watch the video as well. But you have 4 defects. You have pulmonary stenosis, which we just learned about. You have ventricular septal defect, which we just learned about. You have an overriding aorta. So the overriding aorta is kind of interesting because it makes it to where that aorta is really, really close to that VSD now. And what happens is this is one of the other reasons that you have increased blood flow of unoxygenated blood to the body, okay? And then you have right ventricular hypertrophy. So remember how we talked about in the heart failure video, TET spells or hypoxic episodes, and how I said when they're crying and they go blue, that is a concern for tetralogy of Fallot. So the thing about it is it causes more shunting from the right side to the left side of the heart. So more unoxygenated blood to these systems. That's bad, 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 right? So big things that we want to do is putting that kiddo in a knee chest position. Things you can see with the tetralogy of Fallot kid is because you have that chronic hypoxemia, the clubbing of the fingers, the polycythemia, which is that increased RBCs. So you can have a higher risk of having clots when you have increase in RBCs like this. Failure to thrive and grow. Prostaglandins help keep that PDA open, so it might buy us just enough time to make it to surgery. Stage surgeries are used to correct it. So one of the things that they talk about in the video is using things like a shunt to go from the aorta to the pulmonary artery, using things like a stent in our pulmonary for pulmonary stenosis to help widen it, so stuff like that. We can have mixed defects. So for the most part, these are not huge ones that we're going to be testing on. I'll discuss them really, really briefly. So our transposition of the great vessels, this is a really scary one. This is literally where you have the aorta where the pulmonary artery is supposed to go and the pulmonary artery where the aorta is supposed to go. Gratefully, I guess, most of the kids that are born with this also happen to have a VSD, ASD, and or a PDA. And so that's one of the only reasons why they can live until they get to surgery. Okay. Yeah. Hypoplastic left heart syndrome, again, this isn't one that we're concentrating on. It is just a really scary one to see, and what you'll see in a second when we get to the picture, you'll kind of understand a little bit better. So you have a significantly underdeveloped left ventricle, and it does not function the way it's supposed to. It's not effective at pushing that blood out to the body. So oftentimes they need surgery almost immediately. It is life-threatening. So they can look normal at first, but then become cyanotic by the time that ductus arteriosus closes. And really all of the congenital heart defects, once that PDA closes or once that ductus arteriosus closes, that sometimes can be when you see the signs. So sometimes they can adapt pretty well. One of my friends, she had a baby with a very specific type of congenital heart defect, and they didn't find it until they did the critical congenital heart defect screening. And everybody kind of thought that she was being a little overly cautious, or, my friend's a nurse, and then it was discovered that the kid had a significant congenital heart defect. It's not even one of the ones that we learned because there's so many ones out there. But and it was when his ductus arteriosus closed, they started to see the signs. So congenital heart defects can lead to heart failure, and so you guys will learn about that in that heart failures.